Avoidant personality disorder and neuronal linkage. Avoidant personality disorder is more than being shy. It's a chronic pattern of social inhibition, fear of criticism, and feeling of inadequacy. Neuronally, the amygdala become highly insensitive to rejection. The prefrontal cortex struggle to calm fear responses, and the stress pathway keep the body on alert. What a fear of rejection become powerful that the brain starts treating the social interaction like a danger. In avoidant personality disorder, the problem is not just shyness, it's deep neuronal fear circuit involving amygdala, prefrontal cortex, and serotonin. Hi, my name is Dr. Wes, and today we're going to discuss avoidant personality disorder and neuronal linkage. The core idea threat circuits become overactive, emotional regulation and social reward circuits become weaker. The main region and circuits involved in this disease is amygdala, prefrontal cortex, and ACC. That is the mechanism fear avoidance, temporary relief, reinforced avoidance. If we go through the definition, personality pattern marked by social inhibition, feeling inadequacy, and hypersensitivity to criticism or rejection. Avoidance occurs because rejection feels dangerous. Symptoms are stable, impairing, and seen across contexts. Common onset adolescence or early adulthood associated with anxiety, depression. Clinical phenotypes, fear of criticism, fear inferior, avoid new people, social inhibition, low self-worth, and what's connection. That is the key of the avoidant pattern. The person avoids social, occupational, or new situation where evaluation, embarrassment, or rejection may occur. Neuronal mechanism, social cue like face, comments, classroom groups, threat appraisal, amygdala plus ACC predicts rejection. Body anxiety, insula, autonomic arousal, avoidance, withdrawal, silence, escape, relief, anxiety drops briefly, reinforcement, avoidance, inhibit gets stronger. The learning principle avoidance gives short-term relief, so the brain learns that avoiding people is protective for him or her. Amygdala and fear rejection. Amygdala hyperactivity or hyperactivity detects possible rejection or humiliation, amplifies fear before or during social evaluation, can activate when cues are ambiguous, linked with anxiety during emotional regulation. Social cue, amygdala labels it as a threat, anxiety plus shame plus escape urge. Cortical and limbic network, prefrontal cortex, taps down regulation of fear, anterior cingulate, social pain, error monitoring, network results, social cues are interpreted through a threat bias filter. Insults, sweating, heartbeat, nausea, awareness of anxiety symptoms. Hippocampus stores simulation, memories. Stretch axis and neurotransmitters. HP axis as usual. Hypothalamus pituitary axis. Raising of pituitary hormones like ACTH, CRH. Adrenal cortex, cortisol. Serotonin, 5-HT1, 5-HT2. Dopamine in social reward system. Low motivation. Reduce inhibition of fear circuits, GABA, and noradrenaline arousal, tremor, and palpitations. Diagnosis, that is very important. Clinical patterns: feeling of inadequacy, hypersensitivity, avoidance of activities involving criticism or rejection. Assessment: detailed psychiatric history, functional impairment, the role of social anxiety, autism spectrum, depending upon the patient condition, schizoid trait, psychosis, and substance use. Treatment: psychotherapy, cognitive therapy, schema therapy, gradual exposure to avoidance system, social skill training. Medication supports: no specific medication are there, but sometimes SSRI or SNRI, as well as the other medications, should be given to the patients. The SSRI drugs, sertraline, fluoxetine, escitalopram, fluoxetine. The medication supports like SNRI, venlafaxine, and reluctance. Anxiety with depression, low energy, and persistent worry. Treatment: anxiolytic, buspirone, lorazepam should be given to the patients having the AvPD and uh, anxiety in them. The others may include the beta blockers like propranolol, performance type anxiety symptoms such as tremor, palpitation, sweating before the uh, presentations of social exposure. Prognosis: better prognosis depending upon the history, regular exposure practice, family and social support, reduced depression and substance use. Poor prognosis: delayed history, long-term isolation, untreated depression, severe occupational impairment. Genetic vulnerability plus rejection or bullying, threat by brain, amygdala plus ACC, weak regulation of prefrontal cortex get reduced, stress response, insula plus hypothalamus pituitary axis, releasing of cortisol and CNRH. Avoidance habits, relief, reinforced behavior. It's a fear-based personality pattern where social threat circuits dominates over emotional regulation and social reward. Thanks and regards. Please like and subscribe this channel for further discussion on rare diseases. Thanks.